Hi, everyone. Thank you for joining today. This is Ann Cloud from Apt Associates. And today we're going to be discussing some implementing evidence-informed practices in maternal and child health. We have a great team of 3 speakers today. Yes, thank you, great. So we have a great team of 3 speakers today who are going to be discussing their projects, their current approaches, some innovative methods that they're applying to addressing maternal and child health. And we'll be looking at some of these lessons learned across both projects here in the US and some global projects. So we'll be able to tie that together. And basically, we're going to be focusing on some thought around equity, thought leadership, and social determinants of health, collaborating and strengthening knowledge among healthcare practitioners. So our first speaker today is Catherine Sullivan. She is the director of the Carolina Global Breastfeeding Institute. She's going to be focusing on some hospital-based quality improvement initiatives where she's implementing some evidence-based maternity practices that support optimal infant nutrition. So Catherine, I will turn it over to you.
Good afternoon. Thank you so much. Can you hear me okay?
Yes.
Great. So welcome, whether it's morning, afternoon, or night where you are. Really appreciate that you are here with us today, and thank you to Apt for inviting me to present. So I'll be mainly focusing on the hospital-based quality improvement initiatives that we have worked on over the last few years. And I want to take a minute to acknowledge that all around the world, we're all feeling the effects of the pandemic, and some of us are feeling pretty bent or cracked, but we're not completely broken. And all of the speakers today will be talking to you about how we continue the MCH work that we're doing even in a pandemic. So to kind of let you in the door, the Carolina Global Breastfeeding Institute is housed in the Department of Maternal and Child Health at the UNC Gilling School of Global Public Health. And it's actually the last freestanding MCH department in the country. Most have been absorbed up into other departments. And we're housed within that department, but we function pretty independently. So we mainly work on grants and contracts, and there is some teaching that goes on. But we focus in the areas of breastfeeding and chest feeding and birth practices and birth spacing. And we do that through training, research, and service. And we consider ourselves implementation scientists. So we do a lot of public health programming. I also want to take a minute to acknowledge our CGBI team because it's not just me. They are all out on the ground doing the hard work directly with hospitals, with child care centers, and prenatal clinics. Over the years, we have really focused in on the area of breastfeeding-friendly healthcare, and we look at it from a lens of strengthening health systems. And so over the years, we've had different projects that we've been involved with, and I'm going to speak to you today about 3 of those. And we feel that all the lessons learned in these projects can actually be flipped to the global stage. Our first project was Empower Breastfeeding, and Apt Associates was the prime evaluation company that was leading that effort. And the partners in the project were CGBI and also Population Health Improvement Partners, which is a quality improvement group that's also based in North Carolina. So the 3 entities came together to work on this project called Empower Breastfeeding, and the EMP stands for Enhancing Maternity Practices. This is a CDC-funded project, or was a CDC-funded project, and the goal was really to help hospitals through what's called the baby-friendly designation process. And in the United States, that's run by an NGO called Baby Friendly USA. And hospitals have to go through what's called a 10-step process to achieve that designation. This is actually an international designation that comes out of WHO and UNICEF. and there's over 20,000 baby-friendly designated hospitals around the world. So in the United States, we were pretty far behind the rest of the world in terms of the number of hospitals that were baby-friendly designated. And so we recruited hospitals from around the country that were coming from areas that had low breastfeeding scores or rates for duration and exclusivity, and also from states where what's called their MPINC. So CDC has a survey called Maternity Practices in Infant and Nutrition Care, and they give states a score, a composite score about how their hospitals are doing with maternity care practices. So we were really focused on finding those facilities that were in states where the MPINC and the breastfeeding rates were low. And so we recruited over 93 hospitals in 24 states, and this meant that we would be reaching about 200,000 babies annually. The facilities were really representative in terms of the Southeast is where we have our lowest breastfeeding rates. We had hospitals that were serving large Medicaid numbers, very vulnerable populations. We had a military hospital. We had hospitals, rural hospitals that were as small as maybe 200 births per year, but with a 90% Medicaid rate, all the way up to the second largest birthing hospital in the country that delivers over 16,000 births per year. So the first piece of this project was to recruit those facilities and have them enter into the baby-friendly designation pathway and work on those 10 steps. Within those 10 steps, there's about 77 sub-steps that those hospitals have to achieve to prove that they have met the requirements for designation. And so our thought with our group was to create an environment to help them succeed. So we provided a breastfeeding coach and a quality improvement coach to each of those facilities. And they help to guide them through the process of change, and change management is always very hard. We did a lot of training. We used a modified IHI model and held learning collaborative meetings in years 1 and 3. We had cohort calls, and we also did cost sharing for some of the designation fees. In the monitoring, we used a technical assistance approach that met what the hospital was used to using for quality improvement. We identified best practices, and we monitored the breastfeeding rates. I'm really excited to tell you that today, 75 of those hospitals, of those original over 90, I think it was 93, made it to designation. And really our deliverable from CDC was just to get them to that last phase of designation. And we had 77 hospitals that met that. So it was very much a successful project, and we met all of the deliverables. So fast forward, there was another opportunity for our teams to work together on a project called Empower Training. And again, Apt Associates was the lead agency in bringing this project to fruition. And it was, again, a CDC-funded initiative aimed at improving knowledge and skills of the maternity care practices that nursing staff, frontline nursing staff who are working on bedside practices would be able to implement. So the focus was to provide tools and resources to build sustainable training plans, so as their team had turnover, that they could continue to sustain the work. And we wanted to make sure that they were doing competency-based training. So we again recruited around 90, I think it was 87 hospitals in total to actively participate in a lot of the same states where we still see low breastfeeding rates. We created a training manual, a train the trainer, and we conducted regional trainings where we taught facilities how to use this training manual and go back to their own site and teach competency-based care at the bedside. We had a lot of fun doing it, and we had great success with this as well. And we were able to measure how they were doing it. Safety, of course, was a major issue that came up, and we wanted to make sure that they were safely implementing bedside practices. For this project, we had an extremely small window of time to be able to do it. So you can see from this slide, our planning was September to March. then recruitment, and then we did the trainers over about a 2-month period of time. And then we jumped right into the training itself. Our goal was for 80% of the hospital staff to be trained at the end of the project, and we exceeded that. So 81 of the 85 hospitals met that measure. And in total, there were 3,719 staff trained in those 85 hospitals across the country. And at the bottom, you'll see the link. We were able to create modules, online modules at the end of the project so that the training could continue beyond the end of the project. So we're very excited about that that's a free resource for you. So we've taken kind of all of our lessons learned, and we have rolled that into a project called Enrich Carolinas. Enrich Carolinas is funded by the Duke Endowment, which is a private foundation that works in North and South Carolina. And they have a healthcare division, and they have funded us in the past. They're very interested in breastfeeding as primary prevention. And so what we decided to do in this project is take all of our, what we call the CGBI baby bundle, so all of our materials and all of our technical assistance expertise, and roll it into one project. And so we have these different arms: prenatal care, maternity care, child care, and community engagement. And the overall kind of source of looking at all of this is an initiative called LIFE, which is Lactation and Infant Feeding in Emergencies. So we implemented that same model that we used in the 2 Empower projects, where we have a breastfeeding coach and a quality improvement coach working in all of these areas. We've developed materials and resources as well as training. So we've taken the successes from each project and continued to build on it. The other thing that we have done is thinking about how can we take this work to the global level. We have been getting very involved with the UNICEF and WHO Global Breastfeeding Collective, and have worked with other groups, the Emergency Core Group and the Humanitarian Development Task Force. So my colleague, my faculty member, Dr. Anjali Palmquist, is an expert in infant feeding in young children, especially in emergency situations. And so we have been working through that process to scale up some of those activities. On our website, which I'll go in the chat later and add this in for you, we have the life support toolkit, and then we made a modification with the pandemic to make sure that we had all of the COVID-related resources for breastfeeding, community, mental health, and childcare. And those are free links and resources for anyone to use. And then the last area that I wanted to talk about was to say that one of our lessons learned is that we have to center equity at the core of everything that we do. And so through all the projects, we've had different levels of centering that have occurred. Our project team has been cross-trained by racial equity experts. We've had training from the Racial Equity Institute out of Greensboro. We've included measures around bedside practice and also breastfeeding and by race, ethnicity, so that we can drill down and see where some of the institutional bias and practices are occurring. We also do that through observation and interviews with the team so that we can really drill down. The kind of 10-step models are very much equality models, so they're a raise all boats mentality, and we know that that doesn't necessarily achieve equity, and so we have rolled equity into a lot of the work to make sure that we are addressing those deeper pieces and that we are making sure that Black and brown families are treated the same or better in a lot of situations because they need more support. And our own team has gone through a Whiteness at Work series so that we can understand how we are functioning so that we can then provide technical assistance to others. So those are the main things that I wanted to share with you today, and we'll be able to answer some more questions about those projects. So that was quick and probably not detailed enough, but at least you have an idea of the work that we've been doing in the hospital space. to make sure that hospitals are moving through best practices at the bedside. And I will turn it back over to our next speaker.
Thank you so much, Catherine. We really enjoyed that overview, and we'll hold questions until after our three speakers, but feel free to post any of your questions in the chat. Make sure that you have that marked to send to everyone so that everyone on the line can see, rather than just the panelists. That will allow everyone to see the questions, and we'll definitely have time for discussion at the end. So our next speaker is Vanessa Lee. She is from the Health Resources and Services Administration. She's going to be sharing some of her project work around improving care for mothers and babies through state or multi-state quality improvement collaboratives. These are called the Collaborative Improvement and Innovation Network to Reduce Infant Mortality, or Infant Mortality COIN for short. So Vanessa, welcome. And I'll turn it over to you.
Thank you so much, Anne. Can you hear me okay still?
I can.
Okay, great. And hello, everyone. Like Catherine, I'm just so excited to have this opportunity to share an overview with all of you of the infant mortality COIN, as we call it for short, as Anne said. I'm first going to tell you a little bit background on the COIN approach or methodology, then orient you to the current phase that we're in of the infant mortality COIN, and finally share some highlights from each of our 4 IM COIN grantees that we fund. Let's see if I can, okay. So the original COIN concept was actually developed by Dr. Peter Glor of MIT. His COIN has just one I and stands for Collaborative Innovation Network. And that's been described as a team of self-motivated people with a collective vision enabled by the web to collaborate in achieving a common goal by sharing ideas, information, and work. In 2012, the Maternal and Child Health Bureau, or MCHB, adapted his concept to reflect not only a focus on innovation, but also on quality improvement, yielding our COIN with 2 I's, or as Anne said, a Collaborative Improvement and Innovation Network. So MCHB has about 8 to 10 different COINs active right now in the field that we fund, ranging in a variety of MCH topics across the life course. And we describe COINs as both a platform and methodology for participants to engage in collaborative learning together as virtual teams around a common aim, applying quality improvement and innovation methods to spread and scale policy and programs that we think in turn will accelerate improvement in desired health outcomes. So we really have borrowed from collective impact and used those principles or conditions of collective impact in our thinking about the COIN approach. But the 3 core methods that all COINs rely on are really collaborative learning, quality improvement, and innovation. I would say we found most COIN participants love the collaborative learning element of COINs the best. They really enjoy that peer-to-peer sharing through COIN, as well as borrowing from each other, testing strategies they may not have thought of on their own. But most, if not all, COINs do incorporate quality improvement into the work or their projects. And more recently, we've had COINs that are using innovation techniques and tools, which has been exciting. And the great thing about COIN is that you have flexibility in using these 3 methods depending on the topic you're tackling or the teams that you're working with. All COINs start with a desire to tackle a common problem or challenge that they have in common. They then establish a common aim statement or goal that they want to reach together, identify strategies or activities that they think will help them reach that aim, and then select a set of shared measures that they agree to track over the COIN time period in order to assess progress towards meeting the aim. As I mentioned, all of this work is typically done virtually for the most part. Teams are in different locations. And depending on the COIN, they may be at different levels. Most are at the state team level, but we have a lot of COINs that also work at the local and community level. So now that I've given you some background on the COIN approach, I want to dive deeper into the infant mortality COIN. This was the first of all MCHB COINs. It's the oldest. It's now in its 3rd iteration, as I mentioned. It actually began back in 2012 as a pilot with the 13 southern states of regions 4 and 6, which have the highest infant mortality rates in the country. My colleague at MCHB, Dr. Ashley Harai, did an outcomes evaluation of this pilot infant mortality coin. And when she looked at data from 2011 to 2014, she found that early elective deliveries had decreased by 22% in the South versus 14% in other regions. Results in the South also showed that stopping smoking during pregnancy increased by 7%, infant sleeping in the back position increased by 5%, and preterm birth fell by 4%. Other regions only showed improvements of 2% for each of these outcomes measured. So based on these exciting and early successes, MCHB decided to expand the infant mortality coin to the rest of the country and regions in 2014, and that national phase ran until 2017. We're now nearing the end of our third phase of the infant mortality coin, which ran from September 2017 to the end of this calendar year. And our goals in this phase have stayed the same as in previous phases. We want to reduce infant mortality as well as disparities in related outcomes through collaborative improvement, innovation, and the spread and scale of best practices that are found through the coins. So this is a summary of the grantees that we've funded in this round of the coin. So we were able to fund 4, and you see on the far right the list of the organizations that were funded, and they're also in those orange boxes in the middle. The coin team is made up of state teams that I mentioned. So in the blue boxes, you'll see the participating states on each of the 4 coin teams that we funded. There's 21 states in total participating in this round of the infant mortality coin. And finally, on the far left, you'll see we have a data and technical assistance contractor who's supporting the teams with TA and coaching in quality improvement, innovation, data and measurement, and evaluation. And that contract is with APT Associates and their subcontractor, Population Health Improvement Partners. So that's the update on the infant mortality coin overall. And now I just want to take a quick deeper dive into the 4 coin teams with the time I have left. So Project Concern International, or PCI, has the Border States coin, and they aim to increase early prenatal care use by 10% among women in targeted impact areas with 4 social determinants of health measures along the U.S.-Mexico border. So they're partnering with those 4 states of Arizona, California, New Mexico, and Texas. And their coin team measure that they're tracking together is first trimester prenatal care, as well as an optional measure of adequate prenatal care. On the screen here, you see the various innovations that each state team has developed over the project period. They used innovation techniques and tools from human-centered design or design thinking. And while unfortunately I don't have time to delve into all of the innovations you see here, I did want to highlight Texas's clinic workflow for pregnancy testing that they redesigned through this coin process. And through PDSA testing and human-centered design work, this improved clinic flow has resulted in prenatal care scheduling delays cut in half, enrollments in Medicaid doubling, and first trimester prenatal care nearly doubling from 29% to 56% since the first quarter of 2018. One learning that PCI wanted to share was that after rigorously using HCD or human-centered design tools and processes early on with the state teams to understand user experiences and unpack the issue, they didn't actually end up where they expected. And so this process actually led to state teams landing in very different places, which led to very different innovations. So PCI has shared that if we truly listen to user experience, you may not end up where you expected. So be prepared and open to unique and unexpected innovations, but these can contribute new evidence to the evidence base. So flexibility here is key. Also, despite the state teams having very different innovations that emerged, there were still opportunities for rich connections and cross-state learning from each other around methods, data use, and experiences. Our second awardee, UNC Chapel Hill, is the backbone organization for the preconception coin, and their aim is to develop an adaptable model to effectively integrate preconception care into preventive care visits. So UNC identified 13 diverse partner sites across the 4 states that they're working with: California, Delaware, Oklahoma, and North Carolina. And these sites agreed to focus on improving the well-woman visit by co-creating screening tools, systems for making sure women receive the tools, that they answer honestly, and then get the support that they need. State teams and sites were trained also in human-centered design methods and tools, and the common measure that this team came up with to track their progress was the proportion of non-pregnant reproductive age women that were asked about their pregnancy intention in the next year. On this screen, you see some of the lessons and strategies that have come out of the preconception COIN team. One thing I want to share is that screening forms the teams have developed and are testing cover common topics across the site, and clinics have been surprised by the risks they've found within their patient populations. For example, more depression and anxiety than expected has emerged, and less fruit and vegetable consumption than expected came out of the screening. So right now, sites are working to identify and co-design patient education materials and resources to respond to the identified needs that are coming out of these screening tools. If you'd like to check out some of the resources that UNC has developed as part of this preconception COIN, I encourage you to visit beforeandbeyond.org. I think Apt is going to help me by chatting in the link a little later in the webinar. On that site, you can also find things like an issue brief that UNC and their consultant developed around using policy to improve preconception health. They also have a women's health practice bulletin. And finally, there's a website for consumers on preconception health called Show Your Love Today, and that's been newly redesigned by UNC and also will be available in Spanish later this year. The Association of Maternal and Child Health Programs, or AMCHIP, has a COIN on social determinants of health, and their aim was that all state teams will develop, adopt, or improve at least 2 policies and/or practices at the state or local level, which will directly impact social determinants of health. They had the largest COIN team with 13 states on their team. I won't read them all, but you can see them there. There's a nice spread across the country, a lot of interest in this topic, as you can imagine. So about half of the state teams are working to incorporate health equity into the infrastructure of their organizations, and the other half are focused on innovative partnerships to address social determinants of health externally with local and community partners. A few examples of some of the innovations happening within this COIN are things like implementing medical legal partnership, assessing childcare needs across the state, and assisting in the development of policies on the state and local level to address the barrier of childcare for women who seek healthcare during pregnancy and childbirth, and expanding access to doulas by looking at reimbursement issues and birth center regulations. A challenge that AMCHIP has reported is trying to navigate the application of quality improvement methods to policy and practice change, recognizing that their state teams are focusing less on improvements that are amenable to things like PDSAs or Planned Use Study Acts, and more on forming innovative partnerships and the long process to make institutional changes. The other thing they identified is that it was hard to find common shared process measures to track the varied approaches that are occurring across the state teams. Finally, the National Institute for Children's Health Quality, or NICHQ, has a COIN focused on safe sleep, and their aim is to decrease SUID by greater than 10% or more across the 4 states of Arkansas, Tennessee, Mississippi, and New York. They're also focused on reducing racial disparities among sleep-related deaths based through adoption of the ABCs of safe sleep. NICHQ focused more on quality improvement with these teams, and they used the IHI Breakthrough Series and Model for Improvement. The focus with this COIN was to really get outside of the hospital setting and into the community setting. So state teams learned that in order to do that and reach their aim, they needed to expand their partnerships to non-traditional partners and really connect with families that way. So for example, one state trained first responders, such as firefighters, to recognize unsafe sleep environments and offer assistance with getting and setting up pack-and-plays. Another state worked with the Department of Motor Vehicles, or DMV, to show their safe sleep education videos in the DMV waiting areas. A challenge that NICHQ shared with this COIN was trying to assess change or improvement using provisional state vital statistics SUID data, or sudden unexpected infant death data. In some cases, there was just such small numbers of this data that it would be suppressed, and so it was difficult to see or assess if change was really happening. So these teams have tried to look at other sources of data that could help them assess if they're making improvement or not, such as process measures data or data collected at the site or community level. At the end of this year, our contractor ACT associates and their partner population health improvement partners will be analyzing the COIN-wide initiative measures you see here among the 21 participating states, and each of the COIN grantees will be analyzing their own team-specific data, both quantitative and qualitative. MCHB expects to be able to share and disseminate final results, findings, and lessons learned from this round of the infant mortality COIN in the spring of 2021, but I hope some of these early lessons and successes that I've shared on behalf of our 4 grantees today was helpful. And if you'd like to learn more about the 4 COIN teams or be connected to any of the grantees, please feel free to contact me. Thanks so much for your attention. I'll now turn it back over to App to introduce the next speaker.
Hi, Vanessa. Thank you. So our next speaker today is James White. His work primarily focuses on international work, and he is a senior associate here at Apt Associates. He's going to talk about a project today that focuses on strengthening the quality of neonatal and child health services via strategic engagement by the private health sector. James?
Great. Thank you, everyone, and good morning or afternoon, colleagues. My name is James White, and as mentioned, I'm Apps Lead for Global Health Security, but I'm here today representing the SHOPS Plus project, where I've been serving as their clinical advisor. I'm based out of Toronto, Canada. Similar to my colleagues, I just wanted to start by saying that I'm really happy we're here talking about these important implementation issues and lessons and documents, given the impact that we all see COVID-19 having on mothers and newborns and children around the world, and certainly we expect that will continue. As a pediatric nurse myself, I've worked in various different roles, different levels on improving the coverage and quality of services. But today, as mentioned, I'll be specifically focusing on past and current lessons around private sector engagement for reproductive, newborn, and child health and maternal health. And in particular, I'll be focusing on some work we recently completed in Nepal in partnership with the Ministry of Health and several other private partners. I think, though, however, the lessons we'll be exploring are very globally applicable. So first, SHOPS Plus is USAID's flagship initiative in private sector health, operated here by Apt Associates with our sub-partners. And I wanted to start by really defining who is the private health sector. And I think first, we know that means a lot of different things to different people. But we here at SHOPS Plus have really taken a broad lens and focus on all non-state entities. So that includes for-profit and commercial entities, both within and external to the health sector, nonprofit entities, faith-based institutions and organizations, parastatal organizations, associations, networks, and the like. I think in any context, we know that there's a diverse range of actors involved outside of state structures. It's also being increasingly acknowledged that private health sector, whatever it has been defined as in context, has a critical role to play in achieving many of the key health outcomes and sustainable development goals that have been mentioned today. We know from literature that the private health sector, however you want to define it, has been a key source of care for women and children and neonates worldwide. In numerous global settings, in different forms, at different levels, of course, but in some settings being the primary source of care. A scoping review that SHOPS Plus conducted prior to the Nepal work showed a real lack of evidence exploring the scale and quality of those services, particularly around neonatal care. We do know that in some settings, private points of care possess advanced technologies, ultrasound equipment, surgical materials and wards for elective C-section and so on, expert human resources for health and specialists, and certainly private care in many settings can promote the most advanced health outcomes. We know, however, that in those same settings or in other settings, many private points of care are constrained by the same health system challenges that the public sector faces. We know that many private sector points of care are not engaged at all by government, are unknown to government, and thus the quality of care being provided and the outcomes from that care are also unknown. So more systematic global approaches, as always, are needed to explore these complex issues and as we look to expand private sector engagement for maternal and child health, and in particular, improve the quality of that care. I think there is need to discuss why we should engage the private sector and the private health sector in particular in Nepal, which is applicable to other regions. So we know that first and foremost, they should be engaged because neonatal and child health mortality rates suggest that we need more services, both in terms of extension both in terms of quality and coverage. We also know that current caregivers of neonates and children are seeking out private sector points of care, sometimes because it's the closest to their home, sometimes because the quality is perceived as better or is actually better, sometimes because they're referred there. Anecdotal evidence also suggests that there are these referral patterns at local level that are inadequate, informal, sometimes based on relationships between providers, and patients aren't fully aware of their options. Why hasn't the private sector been engaged to date? There's hesitation among public sector health officials for valid and non-valid reasons. More importantly, there are lack of successful examples on how, and particularly clarity on specifically how in their context to do that. We know in general that to scale private sector care, we would need to clarify levels of registration and certification, training, knowledge enhancement, quality of care. None of this is new to many of us on the call. But most importantly, I think, and Nepal shows this, we need to clarify how this interaction between private and public points of care can work for neonatal and child health in particular. So in Nepal, very quickly, we worked in 3 different municipalities, Baratal being quite rural, but with some drug shops, as you'd know them, or small polyclinics, which I'll define later. Narayan municipality is quite remote, but has a bit more in terms of health infrastructure in the private sector. And then Barindra municipality is the most urban here in Surkhet, where is Surkhet Provincial Hospital, the public sector's main neonatal and child health referral hospital. And within these 3 municipalities that we worked in, you have a broad range of private facilities and provider types. When we think about quality of care for public or private, it's many of the same issues. For private sector, and this is not a formal framework, but just sort of 4 pillars of quality that we focus on that must be addressed in some form if you want to improve quality of neonatal and child health care in the private sector. One is improving the enabling environment, which I'll discuss further. Improving knowledge and clinical capacity of providers is, I think, quite self-explanatory. Continuously strengthening the practice environment, I think, is very key, and that focuses on the equipment, the materiel, the resources, the job aids, the other things that are outside of providers' control that greatly influence quality. And then particularly in the private sector, which operate as independent businesses most often, building their financial and business management capacity so that they are truly sustainable. So looking at that in Nepal, we started breaking down some of their classifications of facilities. I won't go through this all, but when we start looking at private sector health facilities in any context, we sort of think about it in terms of whether they're higher or lower level within the health system. And then every country has different names for them, but they typically take this form of polyclinics that are providing more than a few health services, hospitals and nursing facilities that have greater inpatient capacities. And at the lower level, you can call them medical halls or pharmacies or drug shops, what have you. And then clinics, which can take many different size and shape, have different levels of providers, and just typically provide slightly less than a polyclinic. So with that broad intervention, we typically engage the private sector. To improve the enabling environment, Nepal tells us very clearly, this work in Nepal tells us very clearly in other places that segmentation of those private health entities is critical to advancing both dialogue with government, but also future partnership. And segmentation beyond the slide I showed previously. We need detailed segmentation in terms of how are they legally registered as a business, taxation issues, and how they're paying their taxes. What is their health registration status? Are they formally recognized by government or not? What type of business are they? And certification status as part of any private sector engagement effort is critical. So when we start looking at the diverse range of these private facilities and types, we have to also think about the facility. We have to think about the provider. So then you have to look at whether these facilities have all of these certifications, but then also does the provider. This segmentation is absolutely critical, and one of the key lessons from our work in Nepal and that I'm here to share today is how to maybe more systematically do that. in improving knowledge and clinical capacity, that's the common quality trainings we're all aware of, but we know that training is not sufficient in and of itself. So private sector, for instance, can't access the common trainings like IM, NCI in Nepal, which is the Integrated Management of Newborn and Childhood Illnesses, and other trainings have been difficult for private sector to access historically. What we've done in Nepal and we'll be doing with our partner project SSBH there, also implemented by APT Associates, is host private trainings where we're now inviting the public sector to those privately hosted trainings to foster those linkages. Another major issue is for implementing partners, it's often difficult to hire government trainers or to deliver the certified national trainings such as CBIM, NCI. So we've been speaking with USAID and others about how that can be facilitated for private sector and how private sector clinicians can get their hands on these knowledge enhancement trainings easier. Perhaps the most important to me is continuously strengthening the practice environment, and that's what I mentioned before, that knowledge enhancement interventions without equipment, without sound practice environments, and as a nurse myself, I can tell you that without the materials, your knowledge can't be put into place. So private facilities are often and frankly should be expected, as they are private, to source their own materials, to source their own equipment and inputs. But for something as critical as maternal, newborn, and child health, we're recommending that might and does require more targeted solutions. And so in Nepal, looking at not necessarily providing equipment to private sector writ large, but looking at strategic placement of resources, strategic placement of equipment, or providing starter kits of key pharmaceuticals as part of training so that private providers can at least get started in providing those services. And then finally, we did less of this in Nepal because we are at very early stages of private sector engagement. But as these services are scaled, as private sector takes on more responsibility for services, certainly they need to be reporting to government, which is number one public concern in most cases. But we've explored ways they can do that in a short form so that it's not such a heavy reporting burden. We want to invest in longitudinal tracking of referrals between private to private facilities and between private to public facilities so that we can start tracking these outcomes and reducing unnecessary movement of these young patients. And then finally, these private associations, which are at very early stages in Nepal but are quite advanced in other settings, are critical. And that helps you reach all of these private providers en masse. It helps you have focused discussions with government about particular segments of these private entities. So thank you very much. I'm happy to answer any questions. We've really just touched the surface, but I think hopefully I've explained how the private health sector, who at least are classified as non-state entities, can make a difference as we move forward. And my colleague Catherine Clarence, who's the Child Health Advisor for SHOPS Plus, and myself, thank you. Over to you, I think, Lisa.
Hi, just checking to see if you can hear me.
We can.
Oh, well. Okay. My name's Lisa Nichols, and I was supposed to be the moderator, and Anne kindly stepped in when my microphone wasn't working. So now we have some questions in the chat box that I'd love to share. One question is for Vanessa. If you could give some examples of the human-centered tools that you're using.
I believe thanks. I was just unmuted. I apologize. I started talking. I believe our grantee, actually, Project Concern International PCI, is also on the line. So, Catherine, if you wanted to chat in, I know you've developed some great human-centered design toolkits for the state teams that you worked with. But one of the tools that comes to mind that they used early on to, again, sort of unpack the problem and determine where they might start prototyping was user journey mapping. And Catherine, you'll probably do a better job than I of describing that, but really walking through the user experience. And there's different tools to help teams do that. But that sort of guided the teams in determining where along their users and their settings prenatal care, early entry into prenatal care was sort of falling short and where the barriers were. So user journey mapping is one. Another I'll chat in some other tools. I just don't want to get the names of them wrong. But Catherine, from PCI, if you're on the line, if you'd like to chat in some of the tools that you guys developed or toolkits as well, I'll be sure to do the same.
Okay, she responded that, yes, she will respond to that. So right now, I think we have one question for James. Please go ahead. If you'd like to unmute yourself, go ahead, or you can put it in the chat box. From another James, James Garia. Okay. Okay, while waiting for that.
Can you hear me, Lisa?
Yes, please go ahead.
So much. My name is James. I'm calling from Uganda. I do work as the Monitoring and Evaluation Director for USAID Uganda Voucher Plus, which is being implemented through the private sector. So my question goes to my namesake, James. Just thanks for doing a great job. One of the things that I know we are sharing in common, and one of the key achievements we're all celebrating today is strengthening the public-private partnership, which you highlighted in your discussion. So my question is, how can the public sector continue and sustain this partnership with the private sector? Because for our case, private sector used to work on their own, and then the public sector doesn't actually believe in whatever the private sector is doing, and then the two actually complement each other in provision of health service delivery. So really, that's my question for them. Thank you.
Okay,
yeah, thank you so much. Yep. Sorry, Lisa.
No, go ahead, James.
Thank you. Yeah, thank you, James, and thanks for dialing in from Uganda. I think your question is really appropriate, and we hear public-private partnership thrown around as a term a lot. I think specific to maternal, newborn, and child health, we need to emphasize that this is a shared objective. Both private sector and public sector have the same outcomes in mind. With that said, they often have total misconceptions of each other. And what we have found is that if you do this proper segmentation and you say, we understand there are private facilities you are very uncomfortable with working with from a public perspective, but there are private facilities providing a good portion of care to women, children, and newborns. By making the issues open and clear for both parties, not shying away from the difficult conversations that sometimes need to be had about profit, about essential supply of commodities, about access to training. There are shared objectives. And so I hope that in every context, Uganda included, where I've done work long ago, that the public-private agenda really becomes about more of a total health system agenda. How do all of these various types of facilities with different patients, different geography, how do they all work in harmony? And that takes some discussion. But I know that Uganda has a long history of that and is well on its way. So I hope I've answered that question. Thank you.
Okay, I think there was another question about how willing were the entities in sharing more about business license and practice information. How did you develop the trust?
Mm-hmm. Also key to the segmentation, like finding out exactly are they registered, or sometimes they're afraid to disclose. The way we did it was by conducting a service availability assessment, and within that we did ask about specific registration types. They were told they could not, they could disclose or not. All of them did, but we did guarantee we would keep that information confidential in discussions with government. But it allowed us then to go to government with a knowledge of who's registered as a business but not as a health entity, who's a health entity but not a business. Importantly, we did not work with anyone who was not registered with anyone, and so who would be completely informal. we worked with partners who maybe had only partial registration, and that helped with their willingness to disclose. Thank you.
Mm-hmm. Just for those that were interested in human-centered design tools, there's information provided by Catherine from PCI in the chat box as well. We had someone raise their hand. I'm not sure I see it anymore, but Paul, you're unmuted if you'd like to ask your question.
Yes, good morning, good evening, everyone. I'm Paul from Nigeria. I want to ask, are there provisions for whereby USAID provide training for health workers, most especially private health workers, in the most insurgent heated area, most especially in the northern part of Nigeria?
I think James might know more about that than I do right now, because SHOPS was continuing to work in Nigeria, correct?
Absolutely. Here, I'm going to actually go back one slide. And if you'd like to email me at that email address, I can definitely put you in touch with folks who would have more details on our work in Nigeria, but we can source the answer for that for sure.
Okay, I wanted to ask a question about the pandemic and COVID, and if it's had any effect or if there have been notable shifts in reproductive, maternal, or child care during the pandemic. I'll put a link and kindly shared a link with us about an article about prenatal births, fewer prenatal births during the COVID pandemic, but I'm wondering if there are any other trends or tendencies people have seen.
This is Catherine. I'd be happy to speak to this. In our experience that we have working with hospitals, we've seen a lot of different things happen. In an overabundance of caution from infectious disease experts, the normal best practices for rooming in and skin to skin aren't happening. So in a lot of facilities, they began separating mothers and babies and not putting babies skin to skin. And we know that breastfeeding is the first immunization and is protective. And so there was a lot of, kind of jockeying for what guidance to follow. And so I'm really happy to say that CDC and the AAP guidance in the U.S. has come into better alignment with the WHO recommendation not to separate mothers and babies. But that just happened. So the separation was happening for the first 4 or 5 months. And our coaches, the TA that we were providing was very much related to that and making sure that providers were having shared decision-making conversations with families so that they, were informed and could make the choice that was best for their family. So that is one of the big areas in which we have seen a shift, and it's going to take a while for that new guidance to soak in back into the hospitals that they shouldn't be separating them.
Right. Did any of the other panelists want to respond?
This is James. I'm happy to.
Yeah, go ahead.
I think one thing to keep in mind is just, that we are facing both a virus, the SARS virus, which is something that requires medical intervention for patients, but we are facing ripple effects throughout society, throughout economies, throughout basic primary healthcare systems, and this is no surprise to anyone on this call. But I think being prepared for the ripple effects, particularly in newborn and child health, and using the COVID work that's being done now as a way to build stronger systems in the future is something we should be actively talking about so that this doesn't become emergency after emergency, and not to promote the private sector issue too heavily, but again, a total health system approach is really going to help with that. I hope that's answered the question.
Yes, I don't know if we have one last response to that, because I know how much COVID has influenced all of us and all of our practices.
Hi, this is Vanessa. Just to add to what the other two speakers are sharing, I know our preconception COIN team, the state teams are sharing in their kind of pilot clinic sites. They're monitoring whether less women come in for that preventive visit or the well woman visit, and therefore that would reduce their screening for preconception health needs. And then the Safe Sleep COIN team, the state teams are also monitoring whether families, there's still the ability for people like community health workers to actually do those in-home visits that they typically would do with families to provide safe sleep education or help with setting up a pack and play or delivering a crib. So trying to find other ways to do that type of education remotely and also still get cribs and supplies out.
Right. So I see that we've reached our time, and I just wanted to thank everyone for dialing in, and I hope that many people have seen the bridges that are being built, and through these kinds of discussions where we see common threads and evidence-based practice and how that evidence can apply to a number of settings. I know we're all aware how influential a setting is, but also limited resources as well as other constraints affect access. So I appreciate everyone's participation, and you'll all receive a link to the recording and to the slides as well. So thank you very much, and everyone have a good evening. Thank you. Thanks.